pregnancy, for example, anything that might make the procedure complex. I'm also the Director of Undergraduate Studies for Women's and Reproductive Health in Oxford, so coordinate the medical student teaching in Year 5. So I'm going to just take you through a bit of a whistle-stop tour of contraception methods, which I hope you find helpful. Some of it will be interactive, and please feel free just to turn your microphone on, interrupt me if you have any questions or anything isn't clear. So a little bit about the kind of background of contraception, which I find quite interesting. And the first thing to say really is that contraception has been around really as long as societies have existed. And in ancient history, lots of really quite fascinating different methods of contraception have been used by different societies, civilizations, populations. So I've included a list of 3 here that were used in ancient history. We found evidence that these were used by societies in ancient history: crocodile dung pessaries, weasel testicle amulets, and early condoms. So some of you might have heard of some of these methods before, whereas some of you might not be familiar at all. Now, just have a little think, and I'd be curious to think, which would you say, if anyone's brave enough to turn on their microphone and speak, which would you pick out of the 3 of these as being the most effective form of contraception on this list? What would you think would be the most effective? Unfortunately, I can't see if anyone has their hand raised, so please just turn your microphone on and speak if you feel comfortable doing so. Any thoughts about, or anything what do you think would be the least effective, if you're not sure which would be the most? So I would definitely say that the weasel testicle amulet would certainly not be effective for humans, maybe for the weasel, but certainly not for humans. On the other hand, people are often shocked to hear that crocodile dung pessaries have been used as a contraceptive method. Actually, there is some biological plausibility of an effect there. So the way that crocodile dung pessaries may have been beneficial as an ancient method of contraception is that actually they change the pH of the vaginal flora of the vagina microbiome quite significantly, and that probably actually does have quite a helpful effect in preventing or reducing the risk of a pregnancy. Early or first condoms used in ancient history were usually made from animal intestines, actually. Were they effective? Not enough evidence to say really how good they were at preventing sperm entry into the vagina, but early condoms have been used for a very long time, for centuries. Now, moving on to talk about modern history, there is no real consensus on what is defined as a modern form of contraception, And you may notice that the World Health Organization has a different definition to what some organizations, NGOs, and governments use. There are some things that we all pretty much agree on, is that long-acting reversible contraceptive methods, otherwise known as LARC, so that's long-acting reversible contraception, are modern forms of contraception. Now, can anyone shout out a long-acting reversible contraception? Helpfully, there are some pictures on this slide. So what's a long-acting reversible contraceptive method? Tell me. So there's pictures on the slide. Just check and have a look and see that you can all hopefully see and hear me. Still, let me go and see who's in the meeting link. So I can see about 12 participants. So can anyone tell me on this slide, what is a long-acting reversible method of contraception?
Sorry, Neda, I don't know if you can see. I think some people might be typing things in the chat.
Oh, they're typing. I can't see, unfortunately, when I'm sharing.
Okay.
Do you mind just letting me know what people are saying?
Yeah, Samira said implant and Lena said IUD.
Yeah, absolutely right. So There's the implant, so that is a progesterone-only implant, and there's also the IUD. So there are two types of IUD, a hormonal IUD and a copper IUD. Unfortunately, when I'm sharing my slides, I can't, because my slide is taken up by the presentation. I can't see if you write in the chat. So do feel free just to turn your microphone on, or if you wouldn't mind interrupting me and just letting me know what people are saying in the chat, that would be great. Another modern method of contraception is the injection. So that's another type of LARC, long-acting reversible contraception. Now, are modern condoms, are modern pills, are they kind of classified as modern forms of contraception? And there's a bit of a debate around that, and that's because they've been around for quite a while. I mean, certainly throughout the 1900s, and also because they've got a lower failure rate, a lower chance of actually preventing a pregnancy. So whether they're defined as a modern form of contraception is a little bit debatable, although they are, of course, used in lots of countries and very popular methods of contraception. What about the future of contraception? Now, this really does go beyond the scope of what you need to know in your practice and really what affects my practice too. But it may be of interest for you to know that there are some new types of contraception that are being developed and that are coming to the market. So it's likely that none of you have heard of this before, but this is something that's called an intrauterine ball, IUB, rather than an IUD. And the way it works is it goes in as a straight line, but then it actually pops up into a little round shape in the uterus. The idea being that it may be less painful to fit because it goes in as such a thin line and then takes its shape only once it's correctly sited inside the uterus. Now, I don't think it's available in many countries in the Middle East, and it's certainly not available in the UK or in the NHS, and that's because early trials have shown quite a high rate of it falling out. But it's an interesting device just to watch the development of. I'd be very interested to see if this does enter some of the markets soon. And on the right, I've just got a picture that is referencing a type of gel, or what's sometimes called male contraception. Lots of different male contraceptives are in development, although none of them, certainly in the UK, are available on the market yet. So just another interesting development to perhaps be on your radar. So what I'm going to do is share a little quiz with you. I'd be really interested to hear your answers to a few of these questions. So I'm just going to exit this slideshow and get a slightly different website. So hopefully you can see this now. If I go to Mentimeter. Now, I didn't catch the name of my Oxpal link, sorry.
Oh, sorry. I'm Carla. Sorry.
Carla, no problem, Carla. Now, are you able to see, Carla? Are you able to see this Mentimeter quiz?
Yes, I can. It's just a bit complicated because I'm actually listening to some separate teaching on my phone at the same time.
Oh no, okay, so it's difficult for you to chat.
So I'm not sure if people are able to unmute themselves. That would be really
That
good.
would be great because
but I could try and keep an eye on it to let you know if I see
okay.
anything.
That's okay.
Sorry.
So I'm going to ask for people to please just join menti.com. So if you use your kind of any website, your phone, just to go to menti.com. And I want you to answer a few questions. So I'll wait to see if people start, once people start logging in, I should be able to see that you've accessed it. So if you go to the website www.menti.com and you use this code, then I'm hoping you'll be able to access this quiz. So I'll just give you a few moments just to hopefully log in to menti.com and access the quiz. Just waited for a bit longer. No responses so far. If you've been able to access menti.com, do you mind just letting me know by just saying you've been able to access it?
Yeah, one of the students has just put the link in the chat, so hopefully they can join from that now.
Lovely. Great, we've had one response. So the first question is, what is the most effective method of contraception that exists? So what do you think is the most effective method? So we've had one answer so far, IUD. We've had another IUD. See if there's a few more responses. Anybody agrees or disagrees? We've got a like. I'll just give you a bit of time for the others to have a think. Implants, someone's put implants. Condoms. So we've got a few different responses. Implants, IUD, condoms. Anything else that people might think the most effective method? Okay, another implant. Sterilization, but irreversible. Yes, great. Okay, some really good answers. So we're going to come back to what the true answer is here, but some really great responses. So thank you, everyone. Next question. Just use the same link. You don't have to do anything. It should automatically just change. So, what is the percentage failure rate of condoms with typical use? Now, just to explain this question, what I'm asking you is, what percentage of people do you think get pregnant in a year of using condoms as their main method of contraception? So they're not using condoms perfectly, they're using them typically the way people use them on average. So on a scale of 0 to 100%, what is the pregnancy rate? So we've got some interesting responses here. So people are saying the failure rate, I suppose, is fairly high. So between around, that's probably around 5% to probably something like 35, 40%. A few more answers coming in. Okay, some quite varied answers. Great. Okay, so as a group, you're giving condoms a failure rate, meaning a pregnancy rate of somewhere between kind of 5 and kind of 40%-ish. Okay, really interesting. Great. Now, final question for you. So what percentage of pregnancies globally do you think are unplanned at time of conception? So what percentage of pregnancies globally are not planned at time of conception? And varied answers again. So some saying below 50%, some saying above 50%. I'll just wait for a few more answers to come in. Yeah, some saying quite high, so around kind of 80-90%. Really interesting. Great, I'll stop the quiz there. Now, don't worry, we're going to come back to the answers of these questions, but really interested to see, very interesting to see kind of your perceptions on and your thoughts about some of the figures for those. So it's really, really good. We'll come back to that. So next, I just really want to reflect with you, why do people want contraception? So why does anybody go on contraception in the first place? That might seem like a really obvious question. And when I ask students this question, usually they say, well, obviously to avoid pregnancy. And that is true. So people want contraception to avoid pregnancy. But there are lots of other reasons that people want to go on contraception, and lots of reasons why contraception may be a good thing to prescribe for our patients. So not just avoiding pregnancies, but to space out pregnancies. So if someone is thinking about family planning and isn't quite ready for a pregnancy yet and wants to space them out. But lots of reasons that don't have anything to do with pregnancy. So to stop periods, lessen periods, to help with PMDD. Now, by that we mean kind of premenstrual dysphoric disorder, to help with their skin, especially if they've got acne, for example, for some gynae conditions like endometriosis, adenomyosis, as well as for endometrial protection. So what we mean by that is keeping the womb lining, endometrial lining nice and thin when you have conditions like polycystic ovarian syndrome, because we know that can increase your risk of endometrial cancer, or if you're on a medication like estrogen for HRT to protect your endometrial lining from against that estrogen and reduce your risk of endometrial cancer. So lots of reasons why people go on contraception. A lot of it has nothing to do at all with pregnancy. But that's not at all minimizing the important role that contraception plays in preventing pregnancy. And your answers to the questions in the quiz, by the way, were really, really excellent. I'm always interested in seeing how different groups respond to those questions. And I thought you gave some very knowledgeable answers there. And you were right, it's about half of pregnancies globally are unplanned at the time of conception. And lots of you are answering kind of around the half mark. So 44% globally, pregnancies are thought to be unplanned at the time of conception. Now, why is this important? Why do we care about preventing unplanned pregnancy? And it may be very obvious that we're thinking about the human rights of that individual, the pregnant mother, the person who's going to go on to have that baby. But it's not just about the individual, it's also very important from a public health point of view. Okay. Now, out of the 1.9 billion women who are of reproductive age globally, 160 million have an unmet need for contraception, meaning they want contraception but are not able to access it. This is bad not only for their health, but also for the health of their children. And we know that because having a short time between one pregnancy and another increases your risk of being unwell during pregnancy, increases your risk of miscarriage, increases your risk of stillbirth, and increases your risk of neonatal death. So children born within 2 years of an elder sibling have a significantly increased risk of infant death. So children born within 2 years of an elder sibling have a significant increased risk of infant death. And 30% of all maternal deaths are associated with an unplanned and unintended pregnancy. So contraception isn't just about preventing pregnancy. Contraception is something that significantly reduces maternal morbidity, maternal death, infant death. It is a life-saving medication, which is why it is essential for all medical students to have a good understanding of contraception and about providing good contraceptive care. Now, I also just want to reflect with you a little bit about what do people want from their contraception. And this is something that I often this is a question I often put out to some of the Oxford medical students. So in an ideal world, let's say we're living in some contraception utopia where we are able to invent the ideal form of contraception from scratch. Okay. I'd be really interested to hear your thoughts on what you think would make something the ideal form of contraception. So again, I'll ask you if anyone feels brave enough, because I can't see the chat when I'm sharing, just to turn your microphone on and say one feature. What do you think someone would want from the ideal form of contraception? What might one of your patients want from their ideal form of contraception? Take a moment just to have a think.
Can I start?
Yes, please.
I think ideally women would want like less side effects.
Yes, yeah, absolutely. That's a really important one. So something that doesn't have any side effects, right? In a contraception.
Yeah, or at least minimum, because I think like I have a lot of I see a lot of female patients that complain of getting on, like putting on weight or having PMDD, and like these really affect their lifestyle, like to the point that they can't, like they don't know if they should proceed with it, and like using condoms or like any physical form of contraception is not like I think I was talking about the pills, so
Mm.
but the physical ones like condoms are not really the best for prevention of accidents and accidental pregnancies.
Exactly. That's a brilliant answer. Yes, well done. Thank you for sharing that your patients have had that experience. So I agree. I'd say that's one of the top priorities in most of the patients that I see, is that they're worried about contraceptive side effects, especially things like skin, weight gain, mood changes. This is a real priority for people. They want contraception that doesn't have side effects or has few side effects. However, there are some patients who want positive side effects, right? So some people want no side effects and little side effects, but some people want specific positive side effects from their contraception. What might they want?
I think women with PCOS really uh, get the benefit of these contraceptions because it regulates their periods and it can
Yes.
improve fertility.
Yes, so bleeding control is a big one, isn't it? That's a real priority for a lot of patients. So if they do want, if they're looking for specific side effects, often they're looking for positive side effects. So I want help with my bleeding. I want to have regular bleeding, or I want to have less bleeding, or I want to have no bleeding. Yeah. Sometimes they might want positive side effects for their skin. So I've got acne and I want a method that's going to be good for my skin. Okay. So that was a really brilliant answer, and I agree with you. Side effects, good or none, is often something that people really want. What else? Any other ideas from the group? So what else is someone wanting from the ideal method of contraception? What does your patient want from the kind of the utopian contraceptive method?
Can you repeat that?
Yeah. So in an ideal world, if you had the ideal type of contraception, what qualities would it have?
I think it would have either the positive side effects and none of
Yeah.
these negative ones, and
Yeah.
like a very high efficiency, like no chances of accidental pregnancies.
Exactly.
And
So
I think
100% effective, right? 100%
yes,
effective. Yeah. You were
and I
going to say
think
something
it
else.
wouldn't like need like dedication like the pills. You have to take them every day. If you forget one day, you will have like a big chance of getting pregnant if you, especially in the fertility days around the ovulation. So I think
Absolutely.
like a contraception that can, you can like ignore like how the, like I think the estrogen implants in the arms, yeah, I think these last 3 years and
Yes.
they don't require the woman to do like much on her side.
Brilliant, really, really good answers. And you've both of you, between you, your answers, you've covered most of what's on this slide. So one of the top things that people want from their contraception is how effective is it, right? So they want a low rate of unplanned pregnancy or a 0% rate. Okay. Does any method of contraception have a 0% rate of pregnancy? Unfortunately not. But if we were in an ideal world, they would be 100% effective. Now, there was another phrase that you used, the second student who turned on their microphone. They want to be able to forget it, right? To just do it and then not have to remember something. Sometimes in our practice, we call that fit and forget. So you have something and it acts for a while. You don't have to remember to take something every day. So lots of patients really want that. However, I do see quite a lot of patients who actually don't like the idea of having something in their body, something that they're not in control of. They want to be able to start and stop their contraceptive whenever they want. They don't want to have to ask a doctor or a nurse to do it. They might not have access to hospital care. They might not be living in an area where that's feasible. So for some people, actually, they want to be able to stop it when they want, not ask a doctor to have to remove something. We've talked about lack of hormones, lack of side effects, or positive side effects. And the other thing that people might not feel comfortable telling you, but often they do want, is they want something that is not going to like interfere with sex. So, for example, having to put a condom on before sex, or if you're using a natural fertility method like tracking your cycle, which means you can't have sex at certain times, those things can interfere with sex and can interfere with relationships. So that might be another thing that in an ideal world, people would not want from their contraception. I suppose the main point that I want to say is that these are all great things, but there's no one method of contraception that has everything. Everything has advantages and disadvantages. And also remember, what is the perfect contraception method for one patient is not the perfect method for another. So the really good practice of providing contraception care is working out what is best for that patient in front of you. What is their most ideal contraception out of the options that we have? So that brings me on to the next section. So we're going to talk through a few different methods of contraception, and what I would like to do, although some groups are quieter than others, let's see how this works. So what I'm going to ask you to do is, depending on your first name, I've got a list here, depending on what your first name is, I just want you to spend 2 or 3 minutes just researching one of these methods of contraception. You might have prior knowledge based on your medical studies or experiences that you've had with patients, but I want you to, depending on your first name, so if your first name starts with A or B, you're looking at condoms. If it starts at C or D, you're looking at the copper ID. And I want you to try and ask yourself or find out, how does it work as contraception, and what are the advantages and disadvantages? So I'll just repeat that. Depending on your first name, I want you to just have a look at that method of contraception, and I want you to ask yourself, how does that work, and what are the pros and cons, advantages, disadvantages of that method of contraception? Okay, I'll leave this on just for a little bit so that people can see what their method is, and then I'm going to talk through a few different types in a group in 5 minutes, but I'll give you all 5 minutes just to do that activity. Okay, is that clear with everyone? Are there any questions? There are no questions, then I'm just going to stop sharing my screen just for a moment so that I can look at the chat and just make sure everyone understands. So I'll give you all 5 minutes to do this task, and then we will regroup.
Should we write it down, or should
You don't have to write it down. Whatever works best for you, I don't mind at all. I'm not going to ask you to present formally.
Okay, that's good.
I won't put you on the spot. Just going to have a look at the chat. So you've had 5 minutes, so I'm just going to go back to my presentation. Hopefully you can still see me, hear me, and see my slides. Okay, so I'm going to do a lot of talking at you about some different contraceptive methods, but I'll ask for a little bit of input as well, things that you might have covered that I've missed here. So let's start by talking about the non-hormonal methods, okay? The non-hormonal methods. And we're going to start by talking about the copper IUD, or copper intrauterine device. The copper IUD is a long-acting method of contraception. The good thing about it has a very low failure rate, meaning there is a low risk of an accidental pregnancy or unwanted pregnancy. The other good thing about it is that it's very long term, so it can last as a contraception for either 5 or 10 years. That depends on what type of IUD somebody has fitted. It has no hormones, so if we think about our contraception utopia, no hormonal side effects, no risk of weight gain or skin changes or mood changes, and your fertility returns to normal straight after you remove it. However, not having hormones doesn't mean there's absolutely no side effects. So one of the main downsides of the copper IUD is that it can make your periods heavier and more painful. In fact, it does this in most people, so it tends to make your periods heavier and more painful. The other thing is that it needs to be inserted and removed by a trained healthcare professional. That's not always feasible. That can be very difficult, obviously, in a lot of settings. So you need to have access to a trained healthcare professional to have it put in and removed. You need a sexual health screen to have it ideally before we have it fitted. So in the UK, we always do a chlamydia and gonorrhea test before we fit an IUD. There are very few reasons why you can't have it. If you've got suspicious vaginal bleeding that needs investigating, we wouldn't put an IUD. If you have a current pelvic infection, we couldn't put an IUD. But in general, most people can have an IUD. Now, can anybody who was in this group, can anybody tell me how it works? How does it work as a method of contraception? What does the copper IUD physically do? Can anyone tell me? How does the IUD work as a method of contraception? So if no one's sure, so the IUD works because copper is toxic to egg and to sperm. So it's toxic to egg, toxic to sperm, and even if they do meet, so fertilization occurs, the IUD can prevent implantation. Okay, so it's toxic to egg, toxic to sperm, and it can prevent implantation of a fertilized egg. So that is the copper coil. Condoms are the other very commonly used non-hormonal method, and there are actually 2 types of condoms. People might not have seen those or had patients using those, but there are internal ones that can be used inside the vagina, and there are external ones that can be used on the penis. Now, condoms are obviously the way that they work is it's a barrier. It's a barrier that prevents sperm from going inside the cervix and into the uterus. That's how it works. It's also the only method to prevent against sexually transmitted infections. No hormones, so no side effects. It's not going to interfere with mood or bleeding or anything like that. However, one of the main downsides of the condom is that it has a very high accidental pregnancy rate. And that's because we know that people don't use them exactly how they're meant to, and because they can break and tear. And also, they require you having to use them every time you have sex. So it's not like a coil where you have it, an IUD where you have it fitted and then you forget. It's something that you have to use every time, and that might not work in all people and in all relationships. So those are condoms. What about natural methods? So we use the term natural methods to mean any method where somebody is tracking their hormonal changes in their cycle and planning when they have sex around their cycle. So avoiding when they have more fertility and having sex when they have less fertility. There are different ways to do it, and that can include tracking your period dates, tracking your temperature, or tracking how your vaginal discharge changes. A lot of people use all of those measures to kind of create a likelihood of fertility or not being fertile. Now, how that works, that basically works by abstaining, not having sex during your fertile window. No hormones, and there's no medical reasons why you can't use this method. What are the downsides? There's a high failure rate. Okay, so there's a high risk of accidental pregnancy because we know that fertile windows can be hard to predict, and because it does really require you to abstain during long periods of your cycle, which not all people are able to do or is practical to do in our relationships. We know it can take a long time to learn your cycle, learn natural methods, and things like stress, illness, or even being postpartum after pregnancy can affect how reliable the method is. So those are some of the downsides of using natural methods. Now, what about the diaphragm? I'd be interested, and perhaps I'll ask you later whether anyone has experience of patients using this or kind of context where you're working at the moment. I would say in the UK, this is becoming increasingly popular. So diaphragms are a physical cap, like a physical barrier that you put inside the vagina and on the cervix. You insert them before sex, and then you're meant to leave them on for at least 4 hours after sex is finished. Now, how does it work? Again, it's just a physical barrier, so it stops sperm entry into the cervix and into the uterus. What are the benefits? No hormones, no side effects. And some people like that it's not going to interfere with their periods, with their skin, with their mood, etc. What are the downsides? Well, just like condoms and just like natural methods, they have a high failure rate, meaning a high pregnancy rate, because we know that they can sometimes fail and let sperm in, and because people don't always use them exactly how they're licensed to be used. It requires quite a lot of motivation and correct technique to use it each time that you have sex. And it's something that you have to leave in for 6 hours after sex, so that can be a downside for some people, the requirement to leave it in for such a long time after sex is finished. So that is the diaphragm.
Can I add?
Yes, of course.
Why do they need to leave it for 6 hours?
So that's a good question. That is because we know that sperm can survive in the lower genital tract, meaning in the vagina, for quite a few hours. So the worry is that if you remove it too soon, then there might be some viable sperm in the vagina that will then enter the cervix. That is the reason. However, if you leave it on for 6 hours, it's unlikely for sperm to survive after 6 hours in the vagina because of the acidity. So that's the reason. Does that answer your question?
Yes, it does. But what doesn't answer my question is why would anyone use that? I don't see any,
you know
any
what,
positive
actually,
effect for it. Just
yeah,
like
so it's really funny because I think everyone will be having, as we go through, everyone will be having internal thoughts about why would anyone use that, or this seems great, but everyone's internal thoughts are going to be very, very different, and it's just it's such a personal thing. I think yes, I mean, as a clinician, I look at the diaphragm and I think requires a lot of motivation. It's quite tricky to do, and it has a really high failure rate. So why is anybody using this? But actually, I'm seeing a growing number of patients, including really young patients, like in their 20s and late teens, wanting to use the diaphragm because they so want to avoid hormonal methods. So it used to be very in fashion in the 70s, and now we're seeing a bit of a resurgence, which is really fascinating. Yeah. You asked about why we leave it in for 6 hours, and I told you that usually we'd expect sperm to die by 6 hours in the vagina. Can I ask, does anyone know how long does sperm survive in the upper genital tract, so in the uterus, in the tubes, in the pelvis? How long does sperm last after it's passed up the vagina? Does anybody know?
maybe 12 or 24.
It's longer than that. It's longer than that, actually.
20.
3 days or 72 hours.
A bit longer than 3 days, even. A bit longer. So
Oh my
it's
God.
5
5
days.
days.
Yeah,
3 to 5 days.
Yeah, so it's thought to last about 5 days. So sperm only survives for a very short time in the vagina, but once it's entered the uterus, it can last for up to 5 days. That becomes very relevant when we talk about emergency contraception. So perhaps if we have time at the end, I'm very happy to talk about emergency contraception. So that is everything pretty much about non-hormonal methods. So I'm going to move on now to talk about the second group, which is progesterone-only methods. So that brings us on to the implant. The implant is a small rod. It's about 4 centimeters long, and it contains a progesterone, just a progesterone. I think somebody mentioned estrogen earlier, but the implant does not contain any estrogen. It only contains progesterone. Now, in answer to the quiz questions, the implant is the most effective method of contraception that exists. In fact, it is more effective than being sterilized. Okay, there's a lower risk of getting pregnant with the implant than if you're sterilized, which I think just is, blows my mind. It's just absolutely amazing that that can be the case, but it is true. How does it work? So the progesterone in the implant is slowly released. That stops ovulation. That's what I mean when I say it's anovulatory, meaning it stops ovulation. It thickens the mucus in the cervix, and it thins the endometrial lining. So I'm just going to repeat that. The contraceptive implant is progesterone only. It stops ovulation, it thickens cervical mucus, and it thins endometrial lining. That's how it works. What are the benefits? Well, I've told you it's the most effective contraceptive method. It's long-acting, so you fit and then forget, and your fertility returns to normal after you remove it. What are the downsides? Well, the most common reason I see people wanting to remove the implant is because it can have an unpredictable effect on your bleeding. Some people have no bleeding, they might like that. Some people might have irregular bleeding. Sometimes that can be prolonged or very, very unpredictable. So that's the most common reason people want the implant out, unpredictable bleeding. It needs to be inserted and removed by someone who's trained, so that can be a barrier for some people too. So that's the contraceptive implant. Now I'm going to keep going talking about progesterone-only method. So our next progesterone-only method is the IUS, okay, so the intrauterine system. Now, can anybody who was in this group looking at the progesterone coil, progesterone IUS, how does the IUS work as a contraceptive method? The hormonal IUS. Anyone tell me? It's a hard question. So the main way it works is that it thickens the cervical mucus and it thins the endometrial lining. Just to confuse things, in about 25% of women, it also stops ovulation. So that's not the main mechanism, but it happens to stop ovulation in 25% of women. So that's how it works. What are the benefits? Well, it's another one that you fit and you forget. So it has a very low pregnancy rate, and your fertility returns to normal after you remove it. What are the downsides? Well, quite similar to the implant, is that it changes your bleeding pattern. Some people stop bleeding, some people have irregular bleeding, very unpredictable bleeding. It needs to be inserted and removed by a trained person, and you should ideally have a chlamydia and gonorrhea test beforehand because we know it can cause pelvic infections. So that is the hormonal IUS. Now, this is the contraceptive injection. This is another progesterone-only method of contraception. Now, I've got two types pictured here. So this is the intramuscular version, and this is the subcutaneous version. So we've got two types, intramuscular and subcutaneous. Okay, both types are not available in every country, but these are kind of available globally. So how does it work? The contraceptive injection stops ovulation, thickens cervical mucus, thins endometrial lining. What are the benefits? Well, it's fairly long acting. You only need to have it every 3 months. It has a pretty low failure rate, low pregnancy rate, but there are lots of downsides with the injection. Again, it can change your bleeding pattern. Some people stop bleeding, some people have unpredictable bleeding. It's the only method that I'm discussing here where your fertility can take quite a long time to return to normal. Sometimes it can take up to 1 year for your fertility to return back to normal, which is why it might not be a good method for someone who wants to avoid pregnancy just for a few months, but is thinking of trying to conceive soon. It's the only method of contraception where there is evidence of a link with weight gain. I'm not saying that no other contraceptive methods can be linked with weight gain, but it's the only method for which there is evidence of a link with weight gain. So if your patient's priority is not to gain weight, this would not be my first choice. It is also the only hormonal method of contraception where there is a link with loss of bone mineral density. So a link with loss of bone mineral density. So if you have somebody who has a very low BMI, high BMI, or already has osteoporosis, osteopenia, this would not be my number one method. Okay, so that is progesterone-only methods. Now, interestingly, I've just realized that I haven't got the, let me just talk about the progesterone-only pill. So the progesterone-only pill is the last progesterone-only method to talk about. So that is a daily pill. You take it every day at the same time with no breaks. Okay. How does it work? Well, it depends on the type of progesterone, just to be extra confusing. The one that we prescribe most often is called desogestrel. That stops ovulation and it thickens cervical mucus and it thins endometrial lining. It's very, very safe. So my old supervisor used to say, desogestrel is so safe you could put it in the water. And she loves saying that. I don't think I necessarily agree, but the bottom line is desogestrel is very safe. There's very few reasons why you can't take oral desogestrel. Now, what are the downsides? Again, you might have irregular bleeding. And because it's an oral pill, you have to remember to take it every day. And if you have any vomiting or diarrhea, then it might not work. So I've talked to you about non-hormonal methods, and I've talked to you about progesterone-only methods. So progesterone-only pill, injection, implant, and IUD. Any questions about those two groups before I move on to talk about the combined methods? I'll just wait a few seconds in case anybody has any questions.
None of my side.
No, great. Okay, I'll move on. So final group is combined hormonal methods. Okay, combined hormonal methods of contraception. There are 3 types of combined hormonal methods. There's the pill, the patch, and the ring. Okay, so by combined methods, we mean they contain estrogen and progesterone. How do they work? They stop ovulation, they thin endometrial lining, and they thicken cervical mucus. What are the benefits? Well, the patient takes them themselves. So it's either a daily pill or a weekly patch or a 3-weekly vaginal ring. It can reduce bleeding and period pain. Some people find it helpful with premenstrual syndrome or PMDD. What are the downsides? Well, estrogen is associated with a lot more risks than progesterone-only methods. So can anybody shout out one of the main risks that we worry about with combined methods that we don't worry about with progesterone-only methods? I'll give you all a few seconds. What does it increase your risk of? I'm absolutely sure you know this.
I think DVT and
Yeah.
ovulation.
Exactly. So one of the main things we worry about is venous thromboembolism, yeah, so a PE or a DVT. So combined methods significantly increase your risk of a clot. Now, your risk of a clot when you're on a combined method of contraception is still way less than if you're pregnant or postpartum. Okay, for context, it's still much less than if you're pregnant or postpartum, but it increases your risk of a clot compared to not being on anything. So if people already have risk factors, like they have a history of a clot or they have a coagulopathy, we cannot prescribe combined methods. Okay, so it increases your risk of certain things. It's a daily, for the pill, it might be affected by vomiting and diarrhea, but that's not the case for the patch or the ring. And if anyone has risk factors for cardiac disease or for blood clots, like they're smokers, like I said, or they have previous blood clots, we can't prescribe combined methods. Okay, so I just want to summarize a little bit about the 3 groups that I've said. So I've talked to you about non-hormonal methods. So non-hormonal, no effect on kind of cycle and no increased risks, but a lot of them require quite a lot of motivation, especially things like condoms, diaphragms, and the natural methods. Progesterone-only methods, generally very safe, don't increase your risk of VTE. However, they can be a bit of a period or bleeding lottery, so you don't know if you're going to stop bleeding or have irregular bleeding. It's unpredictable. And then finally, you have the combined pill, which is associated with increased risk of a lot of things, including a blood clot. But the good thing about it is that it tends to have a positive effect on bleeding and pain, and that tends to be quite predictable. Usually you don't bleed whilst you're on it, and then you have a bleed during your break. Any questions about that before I move on to talk about efficacy? Okay, so I'm going to talk to you about failure rate. So I'm just going to let you have a look at this. This is what we use in our membership exams in the UK, although different trials will give you different numbers. This tells you what percentage of people get pregnant in 1 year of use of the method, if they use it typical, like real world, or if they use it perfectly. Now, what you'll notice is the long-acting reversible methods, the ones in grey, have very, very low rates, and there's not much difference between typical and perfect, because how you use a implant in the real world is not really different from how you would use it perfectly. There's not much you can do to get it wrong. So if you look at the progesterone on the implant, the pregnancy rate in 1 year is 0.05%, okay, 0.05%. And if you compare that with tubal sterilization, that's 0.5%. That really, I think, is quite an amazing feat of modern medicine. That is something that's so effective and fully reversible. Compare that, however, to condoms, for example, a very popular method of contraception. With typical use, the pregnancy rate in 1 year is 18% with condoms. That's with typical use, and with perfect use, even with perfect use, it's fairly high at 2%. Okay. So as you see patients in your clinical practice, one of the questions that you will need to ask yourself is this method of contraception safe for me to prescribe to the patient in front of me? And one of the best tools that you can use to help answer that question is the WHO MEC. So can anyone tell me, what does MEC stand for? The WHO MEC. I'm sure that you know, so I'm going to wait till someone's brave enough to shout out. What does MEC stand for?
UK medical eligibility criteria or something?
It is, yeah. So this is the UK version, but what I imagine that many of you will be using rather than the UK version is the WHO version. So the WHO have their own version, which is called the WHO MEC, WHO Medical Eligibility Criteria. And it's a guide that tells you whether it's safe or not to prescribe a contraception method for someone with specific medical problems, okay? So that's what I'd really recommend you using when you're prescribing in clinic. It's easy to get online. This is the link. It's free to access, so that you can help with some of your prescribing decisions. Now, I just want to talk about a few specific populations. I'm going to go through this quickly, and then I want to leave time for a few case studies, okay? So what about if somebody is postpartum, so they've just had a baby? It's important to remember that fertility can return from 3 weeks postpartum, so really soon postpartum. A lot of methods of contraception can be started straight away after delivery, whether you're breastfeeding or not. That includes the progesterone pill, the progesterone injection, and the implant. Okay? What about combined hormonal methods? So actually, combined hormonal methods, we generally cannot start straight after someone's delivered. And that's because, well, one of the main reasons is because of the worry about their blood clot risk. So if someone wants the combined method straight after having a baby, we would have to say we need to wait. Usually the WHO says waiting 6 weeks for that risk of a blood clot to go down. What about the IUD, so the hormonal one or the copper one? They can be inserted at the time of the cesarean section or within 48 hours of the delivery. But if they're not, then we have to wait 4 weeks. Then after 4 weeks, we can fit the IUD. Why does it need to be within 48 hours or after 4 weeks? Why can we not do it between? Does anybody know?
Can you repeat the question?
So why can the IUD not be fitted between 48 hours and 4 weeks after a baby's delivered?
I'm sorry, I genuinely don't know.
That's okay. Does anyone else know in the group? It's mainly because of the uterus changing size, so the uterus contracting and involuting, and the worry being about malposition of an IUD. So that's the main reason we either do it immediately or we wait for 4 weeks for the uterus to kind of go a bit closer back to normal, to the kind of regular size. So that's the reason. in adolescence, so the most important thing really to remember is that in adolescence, the WHO says you can offer any type of contraceptive method to an adolescent. There's no restriction based on age alone. Obviously, in your service, it may be worth considering, what the availability is like, whether there are any restrictions in adolescence. But according to the World Health Organization, there shouldn't be. What about people taking enzyme-inducing medication? So can anybody shout out, what do I mean by an enzyme-inducing medication? Can you give me an example of one? What's an enzyme-inducing medication? As medical students, you'll be more up to date on this than me by far. So what about rifampicin, for example? Does that ring a bell? Rifampicin being an enzyme-inducing medication? Hopefully it does. So we know that some medications induce liver enzymes, meaning that contraceptive methods are less effective, okay? And actually, most forms of contraception are reduced in efficacy if someone is taking enzyme-inducing medications for the duration of that medication and for a month after. But there are some that aren't, and those are the injection, the IUD, copper or hormonal, and then obviously non-hormonal methods like condoms, etc. Okay. Now, based on what I've told you so far, what would you worry about if someone was taking a teratogenic medication? What do I mean by a teratogenic medication? Can anyone shout out? What do I mean by a teratogenic medication? So by a teratogenic medication, I mean a medication that might be harmful to a developing pregnancy. So one example would be methotrexate, for example, or Roaccutane for skin. These are commonly prescribed teratogenic medications. Now, if someone's taking a medication that could be harmful in pregnancy, what do you want to avoid? You want to avoid giving them a method of contraception that has a high failure rate, a high accidental pregnancy rate. So you're more likely to want to counsel them about taking a long-acting reversible method like an IUD or an implant, for example, rather than just using condoms alone because of the risk to that developing pregnancy. Okay, so just a few case studies that I want to work through together just to try and consolidate some of this knowledge, hopefully apply it to clinical practice. I'm just glancing at the time. Okay, so case study number one. Let's say you have a 45-year-old. They want to talk about contraception. They, I'm using a lot of acronyms here, but I'll explain them. So let's say they had a blood clot in the past. They previously had a blood clot, KVT. They smoke. Their parents.
So sorry, Neda. I've just got to go into tutorial, so I won't be able to speak at the end, but are you happy to just end the meeting when you're done? Is that okay?
Yes, happy to, no problem.
Sorry for the interruption.
All right, no
Thank you
problem.
so much. It's
Bye.
really great. Thank you.
No problem. Bye. So you've got a 45-year-old, they want to discuss contraception. They have a history of a blood clot. They smoke. Their periods aren't particularly heavy, but they're painful. 3 vaginal deliveries. And she's not sure what method she wants, but she's keen to avoid hormonal methods. She's worried about weight gain. So what would be top of your list? What would be bottom of your list? Perhaps it's easiest to talk about bottom of this. So what would be bottom of your list here for this patient? What would be some of the worst methods for this patient? What do people think?
I think the combined ones.
Yeah, why do you think a combined one?
Because you said it has strong evidence of weight gain.
It's not the combined one that has strong evidence of weight gain. It's another one.
Yeah, I'm.
It's the injection. It's the injection. But you're right. You're right about not prescribing combined methods here. You're completely right. And that is because she has a history of a blood clot. And she's a 45-year-old smoker. So she has a high risk of blood clot, and I would not prescribe the combined methods. And the WHO would agree you shouldn't prescribe combined methods to someone who's had a blood clot in the past and they're 45 and a smoker. Yeah, so agree, combined pills or patch or ring, bottom of the list. And I agree with you, the injection also would be bottom of my list because she doesn't want to gain weight. So that's another thing that I'm going to think, oh, it's probably not a good method for her. What would be a good method for her, do you think? What would be quite good for her? So she's keen to avoid hormonal methods. Yes, sorry. Go ahead.
Copper IUD.
Copper IUD, someone said, and so there was another voice that said something as well.
Progesterone.
Progesterone pill. So let's go through both of those. So the person that said the copper coil, I agree with you that she's keen to avoid hormonal methods, so that's a good one. But what's the downside in this case of giving her the copper IUD? What's the downside?
Oh, the pain?
Painful, exactly. So I would say to her, we could give you the copper IUD, but there's a risk it's going to make your periods more painful. So I would explain that to her. It's still her choice, but I explain that. You said the progesterone pill. I agree that's an option because it might make her bleeds less painful, and it's safe to prescribe for her. It doesn't increase her risk of a blood clot. But I would just be careful in how I counsel her about it because she said she's keen to avoid hormonal methods. I think what would be quite top of my list here would be talking about the hormonal IUD, because I'd explain it has a very, very low dose of hormones, very little systemic absorption, but it has the benefit of making your periods less painful. So what I would talk about would be progesterone-only methods like the POP, the pill, the progesterone IUD, maybe the copper IUD, but explaining that can make her periods more painful, and I would give her the choice, but I absolutely wouldn't prescribe combined methods. So it sounds like we're all kind of roughly in agreement there. Next case study. So let's say you've got a 17-year-old using condoms, history of migraines, periods are not particularly heavy or painful. She likes to have a monthly bleed. She wants to have a regular bleed, and she doesn't want to have any risk of irregular or unpredictable bleeding. So what's top of your list? What's bottom of your list here? I would say that progesterone-only methods would be bottom of my list here. Why am I saying that? Why do I think progesterone-only methods would be bottom of my list?
Progesterone?
Why?
Because migraines?
She can have progesterone with migraines. She can have progesterone with migraines.
Oh no.
It's a good thought. It's a good thought. But she can have progesterone. What about the risk? She doesn't want a risk of irregular, unpredictable bleeding. So which group of contraception? So which group of contraception is linked with a risk of unpredictable bleeding?
The hormonal IUD?
Which group of contraceptive methods? So non-hormonal methods, progesterone-only methods, or combined methods? Which of those is linked with unpredictable bleeding?
Progesterone.
Progesterone, exactly. So progesterone-only methods have a risk of unpredictable bleeding. So that would be bottom of my list. Which methods have a regular bleed? Which methods have a regular bleed?
Combined.
Combined, exactly. Or a non-hormonal method like the copper IUD. I think someone mentioned that before. So I would talk to this patient about combined methods like the combined pill, the combined patch, the combined ring, or about the copper IUD, because with both of those methods, you're going to have a regular bleed. Okay. Case study 3 of 4. So you've got in fact, this one's a little bit tricky. So let's skip this one. Let's go to this one. So you've got a 31-year-old. She's had a baby 2 weeks ago. She's a smoker. She'd like to go back on the combined oral contraceptive pill. Would you prescribe it or would you not prescribe it? What do people think?
I think we should avoid it because she's breastfeeding. We can start her off on the progesterone only.
I would agree with you. She's breastfeeding, and also because she's postpartum, her risk of what is very high?
Bleeding.
Um,
I mean, clotting.
Clotting, exactly. Well done, clotting. So we don't want to give her something that will increase her risk of a clot even more. So I agree with you. I would not give the combined pill. I would wait at least 6 weeks, and I could give her the progesterone-only pill until then. So perfect. I absolutely agree. Now, just to round up some of what we said, so contraceptive is a hard area to work in, and that's because it's not like learning hypertension guidelines or asthma guidelines. There's not first line, second line, third line. If only it was like that in contraception. Actually, it's just about tailoring your conversation, your options to the patient. If you ask 10 doctors to recommend the best contraceptive method, they'll all give you a different answer. So it really depends on what the patient wants. What do they want from their contraception? What's their medical history? There's also very limited evidence about what the side effects are of different methods and who's likely to experience them. So it's a bit of using the evidence the best you can, a bit of trial and error, patient choice, and what you're aiming for with the ideal contraception care is somewhere in the middle, but it's a very hard thing to achieve, I would say. And I just wanted to reflect with you on something else, which is the fact that contraception history, research, development has an extremely dark history, and the use of forced contraception or coercive contraception, meaning pressuring some people to go on a type of contraception, has been used in a very degrading, dark, upsetting way against lots of different groups, communities, societies throughout history. It continues to happen. Okay, and I mention this because we've all talked about how there's a much low failure rate with long-acting reversible contraception, and some are very effective, some are less effective. That doesn't mean we should pressure our patients to go on one method or another. We need to have a good conversation with them and try and meet their needs in a way that suits them, that's not forceful, that doesn't pressure them. It's very, very important, more so in contraception than really most other areas of medicine. And I know we're limited on time, but I just wanted to reflect on a study that was done in the UK looking at people who wanted to have their IUD removed. So this was a study looking at the experiences of people who wanted to have their IUD removed. And what it showed was that people have really negative experiences when they ask their doctor to remove their IUD. I won't read the whole quote because I know we're running out of time, but one of the patients described their doctor as being like a probation officer. What do we mean by that? I mean like a police officer. Yeah. Another one described their doctor as being like a salesperson, Now, you're all training to be doctors, and as you go through your careers and talk to patients about contraception, what you don't want is any patient to feel like you're acting like a police officer or like a salesperson. You want to have a high quality and positive doctor-patient relationship with that person. And in order to do that, it's important to understand how they feel about a contraceptive method, not pressuring them, not coercing them to go on a method that doesn't work for them. Okay, and this is very important because not only is it someone's human right to go on the method that suits them best, if that's safe, but also because it can make them disengage from healthcare, it can make them not trust healthcare, and it can really affect their lives in a lot of negative ways. So I mention this just because it's not good contraceptive care is not just learning the science and learning about the mechanism of action and the pros and cons. It's about really how you speak to your patients and being able to offer them the choice that works best for them. And that's also part of the joy of working. That's why I like working in contraception so much. So like I said, this is what we're aiming for: a little patient choice, bit of evidence, bit of trial and error, and then hopefully trying to work out together. And that is the end of my presentation. And I'm sorry that I've gone 15 minutes over time. I'm just going to stop sharing so that I can see the chat and just make sure I'm not missing any questions. So let me come back to you all and just have a little look. So I've got a couple of questions in the chat. Let me just look at them. So people, you've answered a few questions earlier. Thank you. Thank you, Mazan. Thank you, Zara. Does anyone have any questions for me about contraception?
Which type of contraception can cause breast cancer?
Good question. So there is evidence that any hormonal method can increase your risk of breast cancer. So that includes combined methods and progesterone methods. We think that combined methods have a stronger link with the risk of breast cancer, but really there's evidence showing that any type can increase your risk of breast cancer. We think that the person's risk of breast cancer reduces after they stop the method of contraception. Okay, so it's not like it's a lifelong carried on risk. It's important to note, however, at the same time, that contraception, hormonal contraception, reduces your risk of lots of other types of cancer. So let's think about the combined pill, for example. What we know, the combined pill, we think it increases your risk of breast cancer. It reduces your risk of ovarian cancer. It reduces your risk of endometrial cancer. It reduces your risk of bowel cancer. So if someone uses the combined pill, their risk of dying from any type of cancer is actually less than someone who doesn't use the combined pill. So when I see patients, I always inform them of the association with an increased risk of breast cancer, but I put it into context and I explain it increases your risk of some types, it decreases your risk of others. Is that okay, Mohammed?
It's okay. What about the contraception in Barsha 1 or Barsha 2 in breast cancer?
Contraception in
Barsha 1 and Barsha 2 in breast cancer.
BRCA1 and BRCA2. Is that what you mean? Like BRCA1, BRCA2?
Yes.
So if somebody has BRCA1 or BRCA2, actually the guidance is that you shouldn't give any combined hormonal contraception, but it's something that we can, that's what the UK guidance says. I'm going to check now what the WHO guidance says, so I'll show you exactly what it says. But in the UK, we wouldn't prescribe combined methods, but we would prescribe progesterone-only methods. I'll just show you. Interesting, that's really interesting. So let me show you. So this is an example of something where the guidance is different in the UK compared to the World Health Organization. So I'm just going to share my screen. Mohammed, can you see this document that I'm sharing? Can you see this?
Yes.
Yeah, so this is the World Health Organization medical eligibility criteria. So it tells you, it gives you a number, okay? Can I prescribe a contraception or not for somebody who has a family history of cancer? Yeah. So interestingly, what it says is if someone has a family history of cancer, it gives you a 1. Do you know what a 1 means?
Compare between contraception pills or
So a 1
progesterone.
A 1 means that you can prescribe the method. You can prescribe it. 1 means you can prescribe it. So let me show you. I'll show you in a second. But basically, what the WHO guidance is saying that even if someone has BRCA1 and BRCA2, then they say that you could still consider prescribing it. Actually, in the UK, our guidance says that you shouldn't prescribe it. So that's the difference.
Okay.
I'll show you what 1, 2, and 3, and 4 mean. So when you look at this guidance, and I've set you some activities that use this guidance so you can practice it. So 1 means there's no restriction for using the method. 2 means the advantages outweigh the risks. So 1 or 2 mean you can prescribe generally. 3 means the risks outweigh the advantages, and 4 means unacceptable health risks. So 3 and 4 mean don't prescribe. So if we look at BRCA, this is saying that for combined contraception, you can still, even if there's a family history, you can still prescribe it. That's what the World Health Organization recommends.
So it's safe. Okay, thanks.
No problem. Any other questions?
Thank you so much for this lecture. It really gave me new information for your efforts.
Oh, my pleasure, Lana. Thank you so much for joining. Brilliant. So I'll stop there. We've set some activities for you that practice using the WHO medical eligibility criteria. So that's all clearer in your minds. I hope you find that useful. A real pleasure to teach you, and best of luck with your medical training. And I'll say goodbye for now.
Thanks. Goodbye.
Thank you. Bye.